Hi everyone, welcome to Barcelona. We're joined here by Dr. Lindemann, and we really appreciate her time in discussing with us the challenges in the PARP era. I'm Sabrina Piedimonte, a gynecological oncologist in Montreal.
And I am Elena Olearo, gynecologist oncologist from Azienda Ospedaliera Santa Croce Carle from Cuneo, Italy. We are both editorial fellows at the International Journal of Gynecological Cancer, and we are happy to start with the question for Dr. Lindemann. So, what can we do to improve the detection of patients with oligo-progression during maintenance therapy with PARP?
Yeah, thank you for having me. That's the first thing I wanted to say. And I think that's a real challenge because in the first place, we don't really know how prevalent that is, how often patients present with oligometastatic disease. It seems that the proportion is around about 16-18% maybe. We also do know that these patients predominantly present with disease in the lymph nodes, so it may even be an asymptomatic progression while on PARP inhibitor treatment. That makes it maybe extra tricky to pick up these patients. We also have evidence now that serological markers like CA125, which are often used in the setting of follow-up, may not be good enough to pick up resist progression, and that has just recently been published based on the SOLO-2 data. So I think when we want to aim for early detection of oligometastatic disease, which may be crucial in terms of putting them on another therapy, then I think imaging would be the right thing to do. And obviously scheduling of imaging and the true impact on potentially a survival benefit, imaging the patients regularly is obviously really not known yet.
Okay, so you mentioned the nodal recurrence. So my next question will be, how can we better tailor radiation therapy, surgical approach, and PARP therapy for patients with isolated nodal relapse?
Yeah, that's right. So it's predominantly located to the lymph node, which then makes it probably also more suitable for local treatment approaches. So far, we only have mainly retrospective data on that. Prospective data is on the way. Patients will be recruited to the METO35B study looking at that, but we have evidence also in disseminated disease that there are potentially approaches like secondary debulking strategy or even stereotactic body radiation, which are suitable for patients with specifically maybe oligometastatic disease. So there has been a few studies out there. They're again mainly retrospective studies, predominantly in a second-line PARP inhibitor setting because that's where they first got approved. And there we can see that both surgery and stereotactic body radiation has been applied. And then after that local therapy, the patient was kept on a PARP inhibitor. So most of the patients did not then switch over other systemic treatment right after local treatment, but that was then first done at the next subsequent progression.
So my next question on the oligo-progression is, what are the effects on progression-free survival of combining radical treatment of isolated recurrence site and PARP therapy? Are single recurrence site different from more than one site recurrence?
Yeah, that's obviously relevant because once you apply local therapy, you also want to make sure maybe that improves survival of the patient. So I think one thing which is importantly to notice that nodal recurrences may in itself infer a better prognosis to the patient. We know that from data from patients who presented with isolated metastatic disease to the nodes without that happening on a PARP inhibitor necessarily, that they tend to do better than patients who have relapsed other places. So that's one thing. So that may be something in the nature of disease presenting in the nodes that confers a better prognosis, and that makes it obviously a bit more tricky. So what we do know from the studies which have been done so far is that these recurrences appear obviously during the first or second year being on a PARP inhibitor, then applying local treatment and putting the patient back on the PARP inhibitor would mean that they often have a time to next subsequent treatment of after the local relapse of about 6 to 10 months. So in total, there has been reported at least that patients will be then in total kept on the PARP inhibitor for around about 29 to 30 months. So that seems like a good number, I think. What we also know is that it seems to be worse survival or progression-free survival for patients with multiple sites of relapse compared to one. So there the numbers, that's only shown by one study actually, where they could directly compare those settings, and patients with multiple disease sites had a shorter survival of around about 6-7 months compared to patients with only one site.
Thank you very much.
So now moving on to the part about response to treatment in subsequent lines, we find it rather interesting since we typically consider patients who are BRCA mutated to be more chemo-responsive. However, after receiving PARP, it seems like there's more resistance to the subsequent line. Is that correct? And how do you explain that?
Exactly, and I think that's one of the biggest challenges now where we've introduced PARP inhibitors in first line. So like you said, almost half of the patients will progress on or during PARP inhibitor treatment already in first line. So that puts us into obviously a completely changed landscape already in second line. Again, it started out with retrospective data looking at patients who progressed on the PARP. And again, these were mainly PARP BRCA mutated patients, as this was the patient group who got early access to that drugs. And their response rate to the next subsequent treatment line were much poorer than what we would expect. So that was really just looked at historical controls. Progression-free survival in those retrospective cohorts were just about 4 months maybe. So you would then think that the duration of response on platinum is definitely shorter than you would expect. And again, like you pointed out, BRCA mutated patients do normally benefit quite long from platinum-based chemotherapy. Then after that retrospective studies, we now have also mounting evidence from the phase 3 trials, and not only in second line, but actually now also from first line from the POLAR study, that patients who progressed on a PARP inhibitor were compared to patients who progressed on the placebo, and responses to next subsequent treatment, but also the progression-free survival to the next progression was really much shorter in patients who progressed on the PARP inhibitor. It seems that if patients progress after explanation to the PARP inhibitor, that doesn't to that extent affect second line or next subsequent treatment. So here we need to enter discussion how long is long enough. As you know, in second line, patients could potentially be on a PARP indeterminately, and obviously we have different treatment times in first line depending on which PARP inhibitor you use. So here we really now need to look into how long is long enough for these patients.
And the last question, do you think there's a potential role for AI in identifying these patients with resistance mechanism to PARP?
That's obviously a tricky question to ask. I'm trying to looking a little bit in a crystal ball here, but what I understand at least, that resistance mechanisms are very, very diverse. So they can apply to BRCA reversions, and then also which part of the BRCA gene is reversed. So it's then they have drug-dependent resistance mechanism, but also mechanisms which interplay with the fork stabilization. So I think it's really tricky, and it seems that it may not be only one resistant mechanisms, even in one patient. And we certainly have no idea, coming back to the discussion of oligometastatic disease, if specific mechanisms are tied up to oligometastatic disease. So, and obviously if in the setting where you're confronted with multiple potential mechanisms, the amount of data and the richness of the data would probably ask for more deep learning methods to look for it, and also then to probably match that with therapeutic options, because it's certain that we do need other therapeutic options in a post-PARP progression era. So hopefully AI might play a role here, but again, I think that field is pretty much evolving right now, and I just see that we learn we'll learn quite a lot more in the next years by multiple biopsies, longitudinal biopsies, etc.
Great. Thank you so much. We're so grateful for your time and sharing these practice-changing ideas with us and the readership of the journal. So thanks again, and thank you everyone for joining us.
It was a big pleasure. Thank you.